Hello, and welcome to Expanding PTSD Awareness in Clinical Practice, Symptoms and Impact. I'm the moderator for our session today. My name is John Krystal. I'm professor and chair of the Department of Psychiatry at Yale University. Our faculty today includes Dr. Lori Davis, adjunct professor of psychiatry at the University of Alabama at Birmingham, Hersink School of Medicine. She's also senior research psychiatrist at the Birmingham VA healthcare system in Birmingham, Alabama. Also, Mr. Matthew McDonell, founder and executive director of Next 18 in Milwaukee, based in Milwaukee, Wisconsin. Today, we're going to take a quick but broad look at post-traumatic stress disorder. Post-traumatic stress disorder is so common, so distressing, so disabling, and yet underdiagnosed. And hopefully today's session will provide an introduction to many of the related issues. We'll begin by describing the epidemiology of PTSD, then talk about spectrum of trauma and risk factors, symptoms and diagnosis, consequences and burden of symptoms, barriers to diagnosis, referral, and treatment, and then lastly, challenges of recognition in clinical settings. So let's jump in and talk about the epidemiology of post-traumatic stress disorder, or PTSD. The global lifetime prevalence of PTSD in various populations and overall ranges between about 4% all the way up to about 10%. The one-year prevalence rate for PTSD ranges between 3% and 6%. It's one of the most common mental disorders in the United States, and particularly in certain populations, a particular problem. About 80% of the patients who have PTSD are in the general population rather than in the military population. And that's an important point because many people associate PTSD as a disorder among combat veterans. And while it is common among combat veterans, the majority of people who have PTSD are actually in civilian population. The civilian population rates for PTSD are 2.6 and 6% for men and women respectively, and the rates are a little higher in the military population, close to 7% and 11.7% respectively. Among the general US population, about 13 million adults will experience PTSD during a given year. That's about almost 5% of the population. And 7 to 8 out of every 100 people will experience PTSD at some point in their lives. PTSD can develop at any age and across genders and identities. The incidence of PTSD is about twice as high in women than in men, and the lifetime prevalence of PTSD is 13% in women, 6% in men. Females in the general population experience PTSD for a longer duration than males. The typical age of onset for PTSD is in young and middle adulthood. The median age of onset among US adults is 23 years. With regards to ethnicity, in the United States, PTSD prevalence varies by group, ranging from about 4% in Asian populations up to 8.7% in the Black population. At this point, I'd like to invite Dr. Davis to tell us about types of trauma.
The diagnosis of PTSD is based on an index trauma, which is either experiencing or witnessing a life-threatening or sexually traumatic event, or witnessing the death or risk of death of someone else. There are several types of traumatic events that might be considered higher risk or being a key driver of the cause of post-traumatic stress, such as, in particular, sexual trauma trauma within an intimate relationship, such as physical abuse or sexual violence. Child abuse is particularly damaging and can put someone at much higher risk of developing PTSD. Being kidnapped, tortured, seeing and experiencing war-related atrocities, as well as combat trauma. And then, of course, natural disasters, weather disasters can be a real cause of post-traumatic stress.
Matt, Mr. McDonell, in your work, do you find that the different kinds of trauma play out in different ways with people? Like their early trauma, childhood trauma versus their adult trauma?
I think it does. What we tend to see at our program, which works heavily with veterans and first responders, is when someone is dealing with the PTSD, right? And usually what we relate that to is the replaying in the mind of a specific event, which causes direct distress and fear as if it's happening all over again. There's often the same common thread, and a lot of that is I feel it, I smell it, I taste it, and it's as if it's going over and over again. And from the perspective of the childhood trauma tying into service-related trauma, I do think it has a tendency, because when we have conversations with individuals and they may have had 6 or 7 PTSD causing moments, traumatic moments during service where multiple teammates were lost, or in a fire setting, right, as a firefighter, multiple scenarios where things have happened, but the one or the two that stand out most to them, once they're educated about where their trauma comes from as from children, that is usually the one that stands out most to them. For myself, it has to do with feeling helpless and hopeless. So in those moments when those combat situations happened, the ones that really stood out to me kind of tied into childhood. And it was as if I was reliving my childhood moments all over again.
Thank you. Dr.
Yeah,
Davis?
that leads in, Matt, very nicely to PTSD risk factors. As Dr. Krystal pointed out, female sex puts the person at twice the risk, younger age of trauma, having other psychosocial stressors, such as being divorced, being from a low-income environment, being from certain racial and ethnic sexual identity backgrounds, and then having comorbid, meaning concurrent diagnoses of other mental illnesses, substance use disorder, including drugs and alcohol, and having a family history of psychiatric problems can add to the risk factors for why someone gets post-traumatic stress. So this brings up a point that many people, 90% of the people experience a life-threatening trauma, but only a small proportion of those, but still large proportion of our population get post-traumatic stress. So we're really studying and trying to understand what puts some people at higher risk than others of developing post-traumatic stress following a trauma. So also it could be that the person had adverse childhood events, maybe not particularly abusive or life-threatening, but grew up in a very stressful, vulnerable childhood environment, having a history of a physical illness or disease, and generational trauma adds to that risk. So the cumulative exposure to traumatic experiences and the severity of the trauma also put people at increased risk for developing post-traumatic stress. Matt, anything you want to add to that?
Yeah, I think a lot of what you're saying ties into what I see from our program when it's running. And if I'm going from a lay perspective as a combat infantryman when I deployed, there were multiple scenarios that happened on my deployment where civilians were killed, teammates were killed. Interactions happened on a daily basis where leaders had to make a decision. And sometimes those decisions weren't in the best interest of everybody involved. But at the end of the day, when you look at the perspective of this is a human who is by nature flawed, making a decision, certain situations happened where I personally don't hold any disdain for what we had to do to the enemy. As a child raised Christian, Lutheran, I was taught that if you were bad, there were consequences. And that's a very overarching definition of it. But I was also taught that killing civilians or hurting people that were innocent was this very bad thing. So when an enemy was killed, I don't have nightmares from that. To me, it was a means to justify an end, and I did my job and my teammates did their jobs. What affected me from a morally injurious perspective and probably from some level of PTS was when civilians were killed. We watched it, we witnessed it. Sometimes we took part in it. And that's where the moments for me stick. And those are sometimes where the nightmares come from, right? Like reliving this moment. And I hear this is echoed by many of the participants that come through our program, be it law enforcement, military, EMS, fire. There are those moments, helpless, hopeless, being unseen, unheard, that really ties into it. And on an individual level, what affects me doesn't affect the person next to me. I think where the big issue arises is when those moments happen, there's no validation of the feeling internally. I think that's where it really happens, right? You just witness something on a level from here to here on the spectrum, and no one's there to reassure you, because for my populations, the jobs that we perform, you don't really get the opportunity to stop and think about what you did, because stopping and thinking can get you killed.
Yeah.
Mm-hmm. Thank you.
Yeah. So let's move on to the DSM-5 diagnosis of PTSD. As you just heard about the kind of very distinctive nature of the experiences that people have that trigger the trauma reaction, there are 4 common clusters of PTSD symptoms: intrusion or re-experiencing symptoms, persistent avoidance, negative alterations in cognition and mood, and marked changes in arousal and reactivity. Let's drill down into those clusters in a little bit more detail. So, for example, in what's often called the re-experiencing cluster, you have recurrent involuntary and intrusive distressing memories, distressing dreams that can really disrupt sleep, dissociative reactions, including flashbacks where things feel very unreal, and you may have altered experience of the environment and your body. Intense or prolonged psychological distress, particularly in response to reminders of the trauma. Marked physiological reactions to external reminders as well. With regards to avoidance symptoms, these are the symptoms that people develop to try to protect themselves from getting flooded by their trauma experiences, such as avoidance or efforts to avoid distressing memories, thoughts, or feelings, or avoidance or efforts to avoid external reminders of the trauma. With regards to negative cognition and mood, people will often describe difficulty remembering aspects of the trauma situation. They may have exaggerated and persistent bad feelings, distorted cognitions, and negative emotional reactions. They may experience diminished interest in activities in their daily lives, feelings of detachment or estrangement from others, even people that they're very close to, and they may find themselves feeling irritable and difficulty experiencing positive emotions. With regard to the cluster of arousal and reactivity symptoms, we may see irritable behaviors or angry outbursts, reckless or self-destructive behaviors, hypervigilance, exaggerated startle responses, difficulty concentrating, and also difficulty sleeping. These symptoms have to persist for at least 1 month, and they have to cause significant distress or functional impairment, and they have to be related to the trauma exposure and not attributable to another medical condition. I see we're moving rapidly through time, so I think we probably should move on to the next item. Dr. Davis, what about the economic impact?
Right. We did this study looking at the total cost to society, the excess economic burden of post-traumatic stress in the United States in 2018 added up to $232 billion. Again, when we divide up the civilian from the veteran calculation, because there are more human beings who are civilians with PTSD compared to veterans, the cost to society for civilians added up to about $190 billion. And for veterans, $42.7 billion on an annual basis. About 25 to 35% of that was direct healthcare costs. The remaining costs broke down into non-healthcare costs, such as disability payments, homelessness, legal expenses, and then, of course, the cost of unemployment, loss of productivity, cost to the caregiver. Think about the family members who are having to take out time, attention, get their own healthcare expense from caring for people with post-traumatic stress. All adds up.
To me, the data that you just shared with us, which are in some ways shocking, really tell a story, which is that if we could do a better job in recognizing and helping people to come forward with their PTSD symptoms and get more effective treatments, that we could maybe reduce this incredible economic burden of PTSD that just compounds the subjective distress and functional impairment that we were just talking about.
Yeah, it's truly staggering.
Yeah. Mr. McDonell, anything you want to add about this?
I think the thing that stands out most to me is knowing that the general population, how many humans there are in our country, and how few veterans from a scale perspective. But to see that the numbers are roughly 4 times that, it's kind of staggering when you actually look at it, and it's very sobering to think that the population of veterans makes up what, maybe less than 5%, but the numbers, it's about 20% of the overall spend.
Mm-hmm.
Yeah.
And then the consequences, getting to that, of undertreated post-traumatic stress. There are many barriers to the access to care, both within understanding it as a public health crisis, having providers available and educated, and having treatment options. So this figure kind of shows you that layering on generational trauma with social and environmental stressors, adverse childhood experiences, which contribute to adverse neurodevelopmental consequences of untreated post-traumatic stress early on at the level of adolescence and young adult. We add that on to think about an adult having untreated, unrecognized post-traumatic stress. They're going to have social, emotional problems, and we're seeing too cognitive impairments and complaints. That leads to perhaps self-medication with substances like drugs and alcohol, putting them at increased risk of risky health behaviors, contributing to disease, disabilities, social issues such as divorce, legal problems, financial problems, housing problems, and finally, at the tip, but most concerning, is increased risk of suicidal attempts, suicide behaviors, and suicide mortalities. Part of that also contributes to cardiovascular risk, causing premature death and outcome.
Thank you, Dr. Davis. I just want to remind our audience to send us your questions in the chat. Mr. McDonell, anything you want to add to this complex set of consequences from inadequately treated trauma?
I think the biggest thing I see in my population that comes through our program is it's emotional numbing, self-sabotage, alcoholism, and then inevitably suicidality. Our population deals with it, I think, on an exacerbated level. And it's often what gets pointed to more often than not as one of the downfalls of serving, right? It's you do this job and this is what happens on the back end. I would agree with most of this stuff, and it's telling when you look at this pyramid. As we educated our program, generational trauma, right? If you're dealing with the trauma from childhood, you go into these jobs. Being able to educate where much of this is coming from. One of the things we have at our program, and I know a lot of clinicians use this term, right? We wear these hats. The longer you wear a hat, the longer it becomes harder to take the hat off when you need to. And the longer that this, let's say you wore a hat for 10 years and you never cut your hair. At some point, the hat becomes enmeshed and you can't get it off. So these moments, if we don't address them and we don't treat them, a hat becomes your identity and it gets harder to take the hat off. And I see this more often than not when the older participants come through our programs, and I'm talking men and women that are in their late 60s, early 70s, and some of them have been holding these traumas for 40, 50 years, some of them for 60 years because it's from childhood. And they open up, and they are the ones that have the most physical reactions to those moments, the screaming, the crying, the visible shaking. And I look at our younger participants, men and women that are 19, 20 years old, and from a place of love, I say, this is what happens if you don't address it. Yeah. Right? If we don't address what we've gone through on some level, the longer you hold on to that identity, it doesn't become a part of you. It becomes who you are.
So true. And one of the consequences that's the most worrisome is the suicide risk that you mentioned. So this data that we're looking at on this slide comes from a Swedish study where they looked over they have very, very detailed health tracking systems. And for 3 million people studied from the mid-70s to the late 1990s, examining the rate of suicide in women versus men, just overall, women had 6.4 higher risk, and men had nearly 4 times higher risk of committing suicide, dying by suicide. And then when these investigators controlled for previous psychiatric disorders, the rates of suicide in women and men, comparing those with and without without post-traumatic stress disorder, but who committed suicide, women were at 2.6 times higher the risk, and men 1.7 times higher the risk if they had post-traumatic stress. So 1.6% of the general population, those who succeeded in suicide, were attributed to by having post-traumatic stress. And for those people, just those in the PTSD population, it accounted for 54% of the death rate. So really, also, this is some staggering, sobering information about the consequence of untreated PTSD.
Thank you, Dr. Davis. We have about 4 minutes left in our session, so I'm going to move on because we have a few slides to cover. You know, suicide is such a serious consequence of PTSD, and there are many complexities of life, particularly social isolation, that can contribute to the risk for suicide. So in this slide, what I'm focusing on are barriers to treatment, things that prevent or delay people from getting the help they need. Stigma is very common in PTSD. Our society has a history of shaming victims of terrible situations, and stigma prevents people from wanting to come forward and get the help that they need. Stigma disempowers patients and tends to perpetuate a feeling of shame and discouragement about the possibility of getting better. Treatment can have a huge impact. In the United States, about half of people with PTSD receive some treatment, and only about a quarter of people with PTSD get some kind of specialty mental health treatment. This contributes to the long-term problematic course of PTSD for many people, where they may get better, they may get worse, a kind of a relapsing course. Intervention can make a huge difference, particularly early intervention, support given soon after trauma exposure, even within the primary care context. Improving the access to treatment can help people to get the specialty care that they need and have a much better course than what happens in the untreated group. Barriers to treatment can also be in the diagnosis process. Some of this may be related to the limitations of the DSM. As Mr. McDonell mentioned, some of the key issues that are important to people about shame, guilt, moral injury, and other aspects of the illness often don't figure prominently in the way in which the DSM talks about the diagnosis of PTSD. People have multiple exposures as childhood and as adults, adolescents and adults. And the diagnosis of PTSD tends to focus on an index bad experience, the criterion A experience, as opposed to the cumulative impact of numerous traumatic experiences that people have. And then there's the issue of complex PTSD, which is a more complex clinical syndrome, often responding less well to treatment. PTSD can be a very heterogeneous conditions, and the symptoms of PTSD can overlap with many other psychiatric diagnoses like depression, panic disorder, and others that can make the diagnosis process more complicated and challenging. People may present with symptoms that look like panic disorder and never even mention their trauma experience. And so clinicians have to listen for symptoms that might clue them into the existence of psychological trauma histories. People can be reactive, can have a lot of feelings about dealing with trauma, and may avoid, both patients and clinicians may wish to avoid talking about it at the expense of the patient's well-being. And we talked about stigma. Misdiagnosis and the symptoms of PTSD can complicate the clinical interview, particularly if people have trouble recalling aspects of the trauma, have a lot of dissociative symptoms, are avoidant of discussing it. These can complicate the clinical process. And so often with PTSD, the diagnosis isn't done in a single 10 or 20-minute session, but spans over a longer time period, because misdiagnosis can lead to delays in effective treatment. I realize we are now out of time, but we've, in 30 minutes, toured the world of PTSD, talking about many different aspects, and hopefully you've gotten a sense of just what an impactful process trauma can be. I hope you will look forward to future presentations on this topic. I want to thank Dr. Davis and Mr. McDonnell for their excellent comments today, and thank all of you for participating.
Thank you.
Thank you.